Okay, thank you. I'll start that over. So Medicaid is a state and federal partnership focused on funding health and services for enrolled beneficiaries. And Medicaid reimburses education agencies for medically necessary and appropriate, um, sorry, Medicaid covered services for children and young adults, birth to 21, to include unplanned services and those pursuant to an individual plan of care. And as you may all have heard, there has been a recent rule update. So that's why we are talking about unplanned services today and some information. And Lace has been great and will kind of help you with what the new rules are. And we do include those in the slides today. So the Oregon Health Authority is Oregon State's Medicaid agency and as such has authority over school-based health services Medicaid program and associated rules and regulations. ODE is Oregon State's education agency, and as it pertains to school Medicaid, ODE provides support to education agencies, works to align education systems and processes in schools, and interprets education rules and regulations, and helps navigate the crossover between health and education. And as you can see here today, OHA and ODE partner together to support education agencies. So there are two types of school Medicaid billing. There is administrative and direct. Medicaid administrative claiming, also known as MAC, provides reimbursement for claimable activities related to the administration of Medicaid, such as referrals to medical or dental services, assisting a student or family with enrollment in the Oregon Health Plan, and coordination of Medicaid services. Direct service billing reimbursement for covered health services provided by medically qualified staff. Also, that was the old term. Now we're using SBHS recognized providers, um, pursuant to an individual plan of care. So direct service billing for birth to 5 is done by EIECSE programs, and those programs are required to bill Medicaid per their contract with ODE. And education agencies may also bill for direct services provided to students kindergarten through age 21, and there's no requirement to bill Medicaid for that. And children birth to 21, education agencies provide and bill for services outside of an IPOC, an individual plan of care, such as crisis interventions and screenings. So this slide here is meant to serve as a high-level overview of Medicaid requirements to provide a general idea of how the program works. So education agencies have to be enrolled as a school medical provider. Annual cost-based rates are established by the EA and then reviewed and accepted by OHA. Parent or guardian has received written notification and consented to allow necessary information sharing to bill Medicaid. The child or young adult is Medicaid enrolled and receiving Medicaid covered services, and the health service that is being provided and documented by Medicaid enrolled SBHS recognized providers within the scope of their practice and in compliance with their respective board rules. So this is the time I'm going to pause here to see if there are any questions on that information so far. Okay, I'll keep going. So now we're going to talk about some IPOCs. So the Oregon Health Authority has introduced the Individual Plan of Care, also known as an IPOC, for school-based health services to ensure services are medically necessary and medically appropriate and in alignment with all the students' education needs and Medicaid guidelines. And an IPOC covers a variety of plans and does not replace the IEP or IFSP. And if all requirements are met, then the plans that you see listed may serve as an IPOC. So for example, an IEP, IFSP, and an individualized healthcare plan. And those IHPs also include nursing, OT, PT, behavioral health. On this slide here, you can see this table that lists the elements required to bill Medicaid, and these documents may be found between the IPOC and supporting documentation combined. This is also part of an IPOC guidance doc that OHA has, and it will be listed in the resources at the end. We did want to highlight that if you are considering the use of a Section 504 plan as an IPOC, recommended practice would be to include the detail required for Medicaid billing in a separate but linked document, such as a practitioner plan of care. The combination of the Section 504 plan, practitioner plan of care, and documentation of service provision would contain the elements required for Medicaid billing for non-IDEA services. And the following services are Medicaid covered services that are outside of the IPOC. So they may be performed in relation to or in the development of an IPOC, but do not need to be listed specifically in the IPOC. And these include evaluations and assessments, care coordination and consultation, such as IEP, IFSP meetings, and plannings for new suspected conditions not already addressed in the IPOC, and when provided as directly related to SBHS specified on the IPOC, and any episodic occurrences for chronic conditions such as seizures, allergies, and also asthma. And in the absence of the IPOC, the supporting documentation, service logs for those services must include all elements required to bill Medicaid. Next slide, please.
Thought maybe we should pause. I just didn't know there's a lot of new things here. So if there are any questions regarding this, I just want to make sure that it's clear that we've added new things to our Oregon administrative rules for school-based health services that were effective actually yesterday. No, not yesterday, today's the 4th, 2 days ago, Tuesday. And that includes billing for services outside the plan of care. And so you'll see here where it says like episodic occurrences for chronic conditions. That's something that would be new outside the IPOC. Evaluations and assessments, all of them, regardless of whether they result in being on a plan of care or not, are now covered. So just some things there. Just want to make sure. And if there are any questions, lots of elements in that previous table. You guys will be getting this slide deck from Paula. But lots of elements in that previous table that would need to all be encompassing in your service log documentation if you don't have a plan of care in place in order to bill Medicaid. Okay.
So, thanks, Lisa.
Mm-hmm.
So just a disclaimer here that this is not intended as legal guidance on how to write an IEP. As you all know, the IEP is written by the IEP team based on the needs of the student. But this is just an example of an IEP that would be billable to school Medicaid. So for related services, you can see that the therapy is clearly stated, and also you can see the frequency, duration, and location. And to bill Medicaid, the IEP does not need explicit detail about what the actual therapy provided is. For example, if a child is receiving delegated health care, the IEP would not need to contain a list of all the explicit tasks that the nurse has delegated, but the details of the service provision would be contained in supporting documentation and log notes. And that being said, I am outlining Medicaid requirements. So some districts may include more details in their IEPs, and that's fine. We're not trying to dictate IEP writing, as long as the IEPs contain the elements I've described and are provided and documented by the SBHS recognized providers. In accordance with all relevant rules and regulations, there should be no issues with billing. Next slide. I also wanted to provide information about the way that supervision, training, and consultation could be reflected in the IEP in the program modifications and supports for school personnel section. So as you can see here on this slide, training and supervision of assistants and/or consultation with special education teachers can be billable if written into the IEP. So I'm going to pause here to see if there's any questions before we move on. Okay. Now, written notification and parent consent. So per FERPA and the IDEA, education agencies are required to provide written notification and obtain parent consent to share information prior to billing Medicaid. Education agencies must then provide written notification on an annual basis thereafter. and ODE has both form templates on our website. So I wanted to highlight just a couple of things here. The effective date of the consent is the date that it is signed. So flagging here that getting consent as early as possible will help maximize billing. For example, obtaining parent consent prior to evaluations conducted by SBHS recognized providers would allow for billing for the evaluations. If there is no parent consent signed, then those evaluations are not billable. Also, the parent consent cannot be backdated. And another flag is that a change that has occurred in the school Medicaid rules is that evaluations that are conducted by SBHS recognized providers to determine eligibility for the IDEA or Section 504, but do not lead to a plan, are now billable. So that's why reiterating the importance of obtaining parent consent prior to evaluations is important.
Shelby, could I add there too? This is where that parent consent is so crucial to get early, because in addition to the evaluation and assessment being covered, regardless of whether it results in an IPOC or not, those unplanned services would not be covered if you don't
Yes.
have parent consent in place. Does anybody have any questions on that last section? Okay. This section is newly termed as of Tuesday, school-based health services recognized providers. One of the reasons for that is because we have expanded our rules to allow for behavioral health services to be rendered in Oregon by Teacher Standards Practices Commission, school psychologists, school counselors, and school social workers in the event that an education agency opts to enroll those providers with Oregon Medicaid to do so. So the last term was medically qualified, and because these individuals don't have a medical board licensure, we recoined this term, so this looks a little different. Okay. These are all resources for how to enroll with Oregon Medicaid as both a billing provider, which is the education agency level, meaning Greater Albany Public School District in this case, and also for the referring provider, which is actually the rendering provider in Oregon. These are both requirements of the federal government and as of June of 2024. And so those that are at the supervisory level are required to enroll as referring providers in Oregon, including nurses. Any questions on that? Oh. This is our Oregon administrative rule over Medicaid covered services and school-based health services. And these are health services that are provided in the education setting in support of the child's education to address health-related service needs and devices that help the individual child keep, learn, or improve skills and functioning that adversely affect individual educational performance. And these are kind of line item out what some of those covered services include: evaluations, reevaluations and assessment, care coordination and referrals necessary to integrate health-related services for children, direct assistance with selection, acquisition, or use of an assistive technology device, practitioner to student interactive services, so those direct one-to-one services, supervision provided and documented by supervisory level SBHS recognized providers with their assistants who are performing the covered health services in compliance with their licensing board requirements. And then training and technical assistance provided to or demonstrated with a child by an SBHS recognized provider to include instruction on an assistive technology device or adaptive equipment. And to build this to Medicaid, the child must be present during your training and your technical assistance. I'll pause there. Are there any questions on the services that are covered? Okay. I'm going to dive a little bit deeper into evaluation and assessment. So as we mentioned a couple of times, the evaluation and assessment does not need to be on, it does not need to end in or result in your service being on an individual plan of care to be eligible for billing. And that change actually was effective July 1st of 2024. That you know, Shelby already mentioned that you do have to have that parent consent in place to actually be able to bill for it. So that's an important component to note. But the evaluation and assessment for services are procedures used to determine a covered health service related need, diagnosis, or eligibility on an individual plan of care. Education agencies can bill the Oregon Health Authority for the part of the evaluation, reevaluation, or assessment regarding medically necessary and appropriate needs. This can occur to establish, reestablish, or terminate a Medicaid covered service on the child's individual plan of care, or to develop, review, or revise health service components on the individual plan of care. Reimbursement for an initial evaluation or assessment performed by supervisory level recognized providers includes the preparation of the written evaluation or assessment report. The next slide, we'll talk a little bit more about what's not covered, but I just want to make sure it's very clear that with an initial assessment, when it's initial to the practitioner, meaning that that student might be new to your caseload, might have transferred schools to you, so they're new to your caseload, might have come from out of state or a different school district altogether. If you're working with them initially and you're performing an evaluation or assessment, then you're allowed to include the written evaluation and report writing time as part of your evaluation and assessment time. Following that, once the student is, if you're reevaluating and the student is not new to you, then you would not be able to include that time. That would be a not covered service. Any questions about evaluations? Okay. This is our Oregon administrative rule regarding what services are not covered. We have cost-based rates in Oregon that are based on actual audited expenditures from the prior school fiscal year. Included in those cost setting and cost-based rates. So for example, there's an hourly rate or per minute rate for nurses, for speech language pathologists, for OTs, for PTs, etc. Allowed to be included in that time can be the cost of travel for those service providers, their professional development, such as educational workshops and training. And so these things can be included into the cost-based rate, so they can't be billed separately to Medicaid. In addition, services that are not covered are supervision, parent and training workshops, family therapy, recreation and vocational services, and services provided when an IPOC has expired. Completing paperwork, filing, or copying. Review of records is also allowed to be billed when it's part of an assessment or evaluation, but not outside of that time. And then, as we mentioned before, report writing is allowed as part of the initial evaluation, and then it is a not covered service following that initial evaluation. Any questions regarding the services that are not covered? You guys are so quiet. Okay. Oh, go ahead.
On the IPOC, when you say expired, so there should be a start and end, just like an IEP or 504.
I'm not hearing perfectly. Was it a question that like an IPOC could include multiple terms such as an IEP or 504?
With the IPOC expiration, so there is a start date and an end date, just like the IEPs on the IPOC.
So for example, a 504 plan, section 504 plan might have a start date, but might not have an end date. So the associated health plan, such as like a nurse health management plan or behavioral health plan, may have that end date. It may be open. It may be ongoing until the student exits. So that can look a little bit different depending on the type of plan of care.
Okay.
Yeah, good question.
Lisa, I had a quick question.
Yeah.
So on the previous page, you mentioned that supervision is not covered, but then on the page before that, it talked about how supervision is covered. So I'm just wondering what's the difference?
So I think that's a really good question. So supervision by the supervisory level practitioner. So let's say an SLP who's supervising an SLPA. That time where you're coordinating care with the SLPA regarding students' plan of care, determining course of action, change in course, things like that. That is covered time by the supervisory level practitioner. It is not covered by the associate level or assistant level practitioner. But supervision, like of a student, supervision in the sense of if there is a role where you're supervising other staff, those things are actually, supervision of other staff is actually a cost that can be allowed in the rate setting process. So that's a really good distinction to make. Actually makes me think we should revisit that slide, Shelby. Make a note to just update that so it's much more clear. I think that's a good question. So the supervision of the practitioner to practitioner is covered. As long as, and your individual plan of care might dictate a little bit of that, because if your individual plan of care has minutes related to it, then you would be tied or bound to those minutes, like for care coordination. If that makes sense.
Okay, thank you.
Yeah, yeah.
Can I ask a follow-up, Lisa? Can you hear me?
Yes.
So if we're talking about supervision of an SLPA, does that need to be written into the IEP under supports for school personnel in order to bill for that?
It does.
Okay, thank you.
Can I ask a follow-up question about that? Okay, so if it is not written in to the IEP currently, we cannot bill for it.
Yeah, the IEP is a little bit different than maybe some other individual plans of care, but what is written into there are a couple of exceptions. We'll get into that when we get to procedure codes and diagnosis codes, and we'll talk a little bit more extensively about. There are some exceptions to services that are covered outside of the time documented on an individual plan of care. But the individual plan of care works like a prescriptive document when it's for the IEP and IFSP. Those times you're tied to, so you can't bill in excess, but there are some exceptions to that. For example, the time that you're coordinating care in an IEP meeting would not be validated against time on the individual plan of care, like on an IEP. If there's a new suspected condition in which the original plan of care does not account for like the time that you might have been coordinating care, you're allowed to use a certain procedure code to capture that time and bill for it without validating it against time that's already on the IEP. But if care coordination or like supports of personnel, sometimes we see it there is, or consultation, things like that. If that's not on the IEP, and we're not trying to drive how the IEP is written, it could look like if SLP services are on, and I guess I made the assumption that you're an SLP. Should have not made that assumption, but if SLP services are on, even under related services, if it's very blanket, then everything can get billed under that one blanket headline until you run out of time, essentially. But typically with SLP services, we see, and with nurse services, we see like under related services or under specially designed instruction for SLP, we see more of what's intended to be that direct service time. And then if there's care coordination or consultation, it's kind of spelled out separately. That doesn't have to be done that way for Medicaid purposes anyway. Did I make that more clear as mud, or is that helpful, Amanda?
I'm not sure.
Okay.
So I do supervise an SLPA, so I'm wondering, so even if I'm not providing the direct care, I might like sit in on the session.
Yeah.
Quite a lot actually. So I'm just trying to wonder what I can bill for in that instance. So if the SLPA is billing for their service, would I also bill for my supervision time during that same session?
So you could bill for the time where if you have, like, as part of supervision, if you're consulting with that person to discuss like modifications to the approach or change of like the methodology that's being used or changes to the plan of care, then that's what's covered by the supervisory level person.
Okay, so it would be the follow-up consult.
Yep.
Okay.
Yep.
At some point, will you be going over how we should word that in our billing to Medicaid?
We don't have examples of like the documentation itself, but that could be as simple as like, care coordination with SLPA to like review or revise and whatever their goal is, their approach is, and what you guys were changing. Because there may be, for example, the SLPA may be documenting the direct service, which you would not be billing for, they would be billing for under your supervision. And they're gonna have the indication of, let's say it's like they're working on language. And so let's say they were successful with this specific word 6 out of 10 times, but you're thinking there's a better approach to how, that's kind of what you'd be indicating, like the goal and why the change in course, maybe it wasn't working well, that kind of a thing. Does that make sense?
Yes, so I would be just kind of discussing what it was that I changed about, or pretty much what it was that we discussed
If it was
in terms
a
of,
yes.
would it be a separate note or would it be part of the SLPA's note that I
Separate for you.
to be separate from me? Okay.
That's actually a really good question. There was a board, an SLP. This is not Medicaid related because you guys are supposed to follow your board licensure requirements and Medicaid aligns with that. So I do want to make that clear, but there was a situation in a school district, not yours, where a contracted SLP had essentially like combined or assumed the SLPA's notes and they billed that way, and that is not appropriate. So I just want to make sure. That's a good question.
Oh, no, I'm not suggesting that. I know they need to bill their own stuff separately.
Yeah.
This is just new from what I did last year.
Yeah.
So yeah, it sounds like for that consult time, I can bill for that.
Yep, the consult time.
Okay.
And we kind of
Okay.
call it care coordination, so it encompasses like consult and like those like essentially ensuring that like the service is working, where it's working, timing, appointment scheduling, like all those things that might be collaborating with teachers, parents, other practitioners, in-house out, physician, like all those kinds of things are covered under our care coordination, which can be partially consult. We're now covering referral, so things like that.
Yeah, I was referring to the consult time with the SLPA.
But that would be
Okay.
Yeah. Yep.
Okay. And if it's beyond the minimal requirements for SLPA supervision, is that still bill? Can I still bill for that?
As long as it's in your plan of care and you're within the minutes that are on your plan of care.
Okay. Thank you.
Yeah. Okay. This section was previously, if you've been through one of these trainings before or even recently, we have this section called licensed practitioner recommendation. And we've retermed it medically necessary and appropriate because essentially the licensed practitioner recommendation is a statement that the services you're providing are medically necessary and appropriate. I'm going to go to the next slide. One of the reasons why we changed this is because September 2nd and retroactive to July 25th, the requirement to have a separate piece of paper, a document for licensed practitioner recommendation has been removed from our Oregon administrative rules for school-based health services. It's important to note that if GAPS is still billing retroactively for any services that were rendered prior to June 30th of 2025, this element would still be required for those services, but won't be for anything from July 1 this year moving forward. The reasoning for that is that the Oregon Department of Education and the Oregon Health Authority, along with our early periodic screening, diagnosis, and testing team, which is EPSDT at OHA, did quite a lot of research and extensive background work to determine that what you guys do in your processes to determine eligibility or that they are not eligible during the evaluation and assessment process really meets the requirements of what is medically necessary and medically appropriate. So this was one thing that was a win for us in being able to remove another piece of paper that you guys have to collect. annually, and so it's a reduction in paperwork, a reduction in effort, so it was a win for us. That doesn't happen very often with Medicaid, so yay for you guys. But I just want to make a note that the licensed practitioner recommendation still is in effect for those services that were rendered up through June 30th, 2025. And in Medicaid, you have 12 months from the date of service to bill. So there's potential that GAPS is still billing for those things, and that would be required. It's important to note that unlike the parent consent document that must be dated the date that they review or receive it, and not retroactively dated, I guess I should say it that way. From that date forward, you can bill services. As for the licensed practitioner recommendation, you could be recommending the service through that evaluation and assessment process in an IEP meeting, for example, and then maybe this form doesn't get signed until a couple days later, that type of thing. As long as the form has the dates of the IPOC that it aligns with on it, the date that it is signed by the practitioner is irrelevant, as long as the billing claim doesn't get submitted to the Oregon Health Authority until such time that you do have this form in place and it's signed. Moving forward, you won't have to do any of that or worry about that for those services rendered July forward this year. And pause there, ask if there's any questions regarding that practice. Just seeing someone's in the waiting room. I don't know how long she's been there. Okay. Any questions?
For that.
I wasn't sure if that was a question, Paula, or if that's.
So if our billing platform it's something that I'll have to work with our billing platform, because right now claims won't be processed without
Correct.
the recommendations. Okay.
That's correct. So Paula, just so you're aware, we are OHA and in ODE are in the process of trying to establish a meeting with our billing vendors to give them updates on this information. We believe it's probably the 18th or the 19th of September that we kind of had a heads up on it, but we're going to have a formal meeting with them, in which we'll discuss this. I don't know when or how, if they have a manual process to like override this or not. So just so you're aware, we are trying to meet with them to help them be abreast of this situation. So
Okay, thank you.
yep. Okay. I think I already mentioned all of these components. Let's skip to this. What is medically necessary and medically appropriate? This is a link to our EPSDT OARs, not our school-based health services. Because our school-based health services Oregon administrative rules actually follow the exact same definition as EPSDT. And what this means for you is that the services that are being rendered by school-based health services recognized providers within their scope of license, within their scope of practice, must be safe, effective, and appropriate for the student, and generally recognized by the relevant scientific or professional community based on best available evidence, and that the services are impactful in improving access to care, the ability to actively participate in care, work, school, or social activities, and they're not solely for the convenience of the student or the provider of the service. Don't laugh at that last little part. We know you don't have time for convenience. Sorry. Okay, any questions on medically necessary and medically appropriate? Okay. This next section is on what we call diagnosis codes, which are ICD-10 codes and procedure codes. And this is the diagnosis codes or ICD-10 codes are essentially showing what is the why are we providing services, and the procedure codes are representing what the service was. So diagnosis codes or ICD-10 codes can be something that you collect from a primary or from a physician as a primary diagnosis code when it fits the reason you're providing therapy or service. Gosh. And then if this child does not have a physician's diagnosis or an overarching primary diagnosis that fits the reason you're providing services within the scope of your practice, you can use an ICD-10 code for signs and symptoms. So you can assign a signs and symptoms code that best fits the reason you're providing services. Using best practice is to use the most specified code to ensure claims are being paid. There are many unspecified codes. For example, autism there's different distinctions of autism, but there could be an unspecified code for sure that would pay. But when we move into codes that are more associated with signs and symptoms of disease, then those that are unspecified tend to be under what Oregon has a funding line that the Health Services Commission establishes every October, determining what's going to be above or below that funding line for payment for budgeting type purposes. And so those procedure codes and ICD-10 codes that are above the funding line typically need to have the most specificity in order to be processed for payment. So that's just best practice. In the event that something comes back, an ICD-10 code comes back that's below the funding line for payment and denied, then there is the opportunity to come back to the practitioner. Medicaid coordinator could come back to the practitioner and say this was denied. Is there another appropriate ICD-10 code that could be applied and revisit rebilling the service? So I'm going to pause there. Are there any questions about ICD-10 codes or diagnosis codes?
I just want to let everybody know that Desktop did add the prioritized list under resources in Desktop. So you can type in the codes there and you won't have to have a separate thing. So it is under resources in Desktop now.
That's awesome. I didn't know they did that. That's really cool. That's a huge asset. Okay, very good. Procedure codes and modifiers. Procedure codes, of course, are those codes that identify the specific service that's being provided, and then a modifier describes like the discipline type that's providing the service. There's also modifiers that identify the plan of care type and whether telehealth was being rendered. Modifiers are something that typically the practitioner is not manually entering themselves because your billing vendor systems have this information tied into it. So when they establish a login for each of you as practitioners, they will attach the appropriate modifier in the background for claims data for your licensure type. I do believe, and Paula can probably attest to this better than I can, that if you're providing telehealth, I think that there's something you can check that will automatically attach the telehealth modifier for you. And then depending on the plan of care type, I believe it's pulling in and attaching the type modifier associated with the plan of care. So for example, if it was a Section 504 plan with link plan, there would be a different modifier code than there would be for an IEP. Attached here are also references to our procedure code and billing instructions matrix. And this gives you the entire list of procedure codes that are available for use for school-based health services currently in Oregon. We did just add 4 new procedure codes to this list in the area of behavioral health, 2 of which were group procedure codes and then 2 others. If you find that you're working through the procedure codes and billing lists, and especially those of you who have potentially worked in the private setting or community setting and are not working at a school district in the education setting, might be familiar with other procedure codes. If there are other procedure codes that you're interested in using that are not on this list, please reach out to us and we can do some investigating to determine whether we can request them being turned on for use for practitioners in the education setting. We expanded this last year, well, actually this year, I think it was in May, we expanded our procedure code list from 18 bundled codes to about 180 codes. The reason for that is that when we expanded our Oregon administrative rules to allow for different types of plans of care, additional practitioners, expanded services such as unplanned care and personal care services, things like that, we needed to add more procedure codes. With individual plans of care being expanded past an IEP or IFSP, we had to have other procedure codes that could be used for other plans of care. These codes here were part of our previous list. These still exist and they're still turned on and still can be used. And these were some commonly used codes. It's important to note, though, that some of these codes are only allowed to be used for services on an IEP or IFSP, so IDEA related services. The first two codes, T1024 and T1018, may only be used for evaluations and assessments associated with determining IDEA eligibility. T1018 can be used for any direct therapy by any practitioner associated with an individual plan of care that is an IEP or IFSP. The same for G9007 for an IEP IFSP meeting, and then G9012. And G9012 is the procedure code I mentioned before that can be used temporarily when you're coordinating care for a new suspected condition that's not currently addressed in the individual plan of care. That's a temporary use code until such time the plan of care has been adjusted to accommodate, or maybe doesn't need to be. So it's not going to be, the additional coordinating care is not going to be happening. I just want to make sure that it's clear. The bundled codes that are IDEA related can be used by any practitioner, but they can only be used for those services that are IDEA related. So if you're billing for unplanned services, if you're billing for such as crisis intervention that are not on the plan of care, if you're billing for services that are associated with a 504 plan, you would have to use other procedure codes that are not tied to IDEA. So, I want to make sure that that's understood, and then if there are questions, I'm going to give you guys an opportunity to ask questions about procedure codes. Okay. We often get lots of questions about billing for group therapy or concurrent therapy. And so we wanted to provide a scenario and how that would look in your documentation. This is just one scenario, of course, because not just SLPs provide group therapy. So an SLP providing group therapy to 3 students for 30 minutes would be billing for each individual student for 30 minutes using procedure code 92508 for group therapy. The modifier in the background attached to the SLP service is GN. Of course, I think that's something that you guys are not actually entering, but is being entered for you. You would be identifying that the number of students in the group is 3. And then in the background, your billing software is adjusting the cost for each of those 30-minute sessions for the students by 3. So you would document, if you had 3 in the group, for Joe, Jane, and Josh, you would document each one of those at 30 minutes with 92508 and indicate that the number in the group was 3. In the background, the cost of the service would be divided by the number in the group by your billing software, so you don't have to worry about that. Do you guys have any questions about billing for group therapy? Is that a question, Paula?
Oh, they just asked me a question. I'm sorry, Lisa.
Okay. These next 2 slides are just a little bit more information about the procedure codes regarding care coordination. G9005 can be used for coordinating care by school-based health services recognized providers within their scope of practice. And this includes coordinating care with special education providers, physicians, and families to support a Medicaid enrolled students covered health service and in support of special education goals and objectives in the IEP IFSP. This also includes, this is the code you'll be using when you're billing for that time that you're consulting with the SLPA, for example, or the associate or assistant license level person that you're supervising. So this would be the appropriate code to use for that. And then G9007 is for the portion of time that you're spending in a conference or scheduled meeting to include the IEP or IFSP in which your medical expertise are being used. At no time should SBHS recognized providers bill for the entire meeting time, as there is assumed by our federal Medicaid agency that components of this meeting are, of course, academic in nature, which Medicaid will not cover. But to the best of your ability, you'd be documenting the time in which you're participating, using your medical expertise, being called on, presenting, and such. And of course, the G907 is for that. And then, yeah.
About that last one. If the child is present, does that matter in either, in the top one? The
No.
coordinator? Okay.
And often they're not in the IEP meetings, for sure.
But if they were present, that's okay also to bill for that. G9.
Yes.
Okay. Thank you.
Mhm. G9012 is that temporary use code for more coordinated care than maybe was intended originally when you wrote the original plan of care. This is for a new suspected condition that is not currently addressed in the plan of care. So examples of this might be a student who has a brain injury and then in addition to that has developed a seizure disorder. And so there's need for additional care coordination, maybe with other practitioners, with family, with classroom teacher, with the supervisory level and an assistant and so on. Okay, we mentioned modifiers. So I just want to make sure that it's understood if you are performing telehealth or telehealth is being provided, that is to be assigned when the services are using audio and video interactive technologies. You would not have the G2 modifier, or I don't think you guys even click like type in GT. I think you maybe click a box in C's desktop after providing telehealth. It does require that you indicate the location of the student and the practitioner. And examples of that would be the student location can just be what school they're at, for example, Willow Elementary. And the practitioner's location would be their city and state. You don't have to get so specific as to being, we have been asked, like, do we need to note like what room the student is in? And that's not necessary. And we would not add a modifier for telehealth if you're providing using synchronous audio, like telephone only. So just making sure that that is well understood. Any questions on telehealth? The next section is all on service documentation. Service documentation, of course, is critically important, and all school-based health services recognized providers must document the provision of health services as per their individual licensing board rules, regulations, regardless of the setting they're in. Complete and descriptive documentation of health service delivery substantiates compliance with IDEA in Section 504 and provides evidentiary support in response to due process complaints and state dispute resolution processes. And documentation supports high quality health service delivery and mitigates risk and both liability to the individual and the district, and helps ensure that students receive the services that they're entitled to. This is a link to our Oregon Administrative Rule for service documentation and for record keeping requirements. Some key points are that record keeping must conform and adhere to federal, state, and local laws and regulations. School-based health services provided by recognized providers must be documented within their respective scope of practice and in compliance with respective board rules and requirements. It's important to note that Medicaid aligns with all of your board rules on documentation. However, in order to create a pathway for payment, there are a couple of elements that Medicaid would be required to have that might not be in your board rules, such as the ICD-10 code and procedure code. But in order to make payment and have a claim, you would have to have those elements for payment purposes. And then records must include information necessary to support each health service billed by the medical provider. And then documentation must be maintained for a period of 7 years from the date of payment. So I mentioned before, Claims can be paid or billed, 12 months from the date that they were rendered. And so if you're, depending on the practice of gaps and how frequently they're billing claims data, you could be retroactively billing. The date a claim is paid is the date by which you have to maintain documentation for 7 years and not move forward. That's important to note. I always say best practice is 8 years because you've got that 12-month period. And then claims must be supported by documentation that includes all elements of supporting the service is necessary and appropriate. And that includes that diagnosis and procedure code and was provided in accordance with all applicable rules and regulations.
I have a question about maintaining the documentation, but I can't walk, I'm trying to talk louder. Is that what we enter into desktop, is that the documentation and is that maintained for the 7 years? Or do you desktop keep that for us, all your therapy notes and everything? Yep. Okay.
Paula, was that a question for you guys? Because we can't hear if someone's not up at the mic, we can't understand what's being said, so we weren't sure.
Sorry, Lisa, yeah, I was able to answer that question.
Okay, cool. Okay, thank you. Okay, so for service documentation, every treatment or therapy visit provided must be documented for all individuals served, and service documentation must be completed in a timely manner, include the date of service, and be in accordance with your licensing board requirements. It's recommended to use professional language that demonstrates your clinical skill and report objective data to support goals and explain your decision-making rationale for treatment and recommendations. This is a reference to our Oregon Administrative Rules for Documentation and Record Keeping, and this gives a specific list of what is required in your service documentation. The date of service, the Medicaid enrolled child or young adult's full name, their Medicaid ID number, which that Medicaid ID number is often something that you guys aren't applying, but your billing vendor system is probably applying for you in the background. An ICD-10 code, the name of the school medical provider, meaning like the education agency. So typically your forms or the forms that would be printed out would have a letterhead or the name of your education agency on it. The name of the rendering provider performing the service, the name of the healthcare provider supervising the service, if there's supervision happening, if that's applicable. Whether the service is medically necessary and appropriate, the need for the service, location and duration of the service. Sometimes, as we mentioned before, some IPOCs might not have a frequency and duration, might not be as explicit as an IEP or FSP, and it might be more in the realm of a nature, extent, or units of service. And that would be an example of that could be like a diabetes health management plan associated with a 504 plan, where it's not necessarily spelling out 30 minutes once a day type of a thing. It might be a little bit more not like as needed, but so to speak, where you're allowed to offer that nursing service when it needs to be offered. So that kind of covers that term. Matrix and units is a little bit new, and it's newly in our rules, and it's also in the federal guidance to allow for a little bit of flexibility to bill for those other plans of care. And then if it is a group therapy, the number in the group. Any questions on the elements needed in service documentation? If there is an individual plan of care, sometimes some of these components can be found in that plan of care as well, alongside your service documentation. Okay. These are some best practices recommendations for your documentation. Ensure the date's correct. I know that seems silly, but in a PERM audit, which is an audit from the federal agency on your state agency, which does include review of records for school-based health services. And so every 3 years, it's normal that records get pulled for review as part of an internal audit on the state agency, and they look at education agency records. And one of the things they ask for is attendance records of the student. And so they'll match the dates the student is absent with the dates of claims or the dates that you guys have billed services. But just ensuring that the services are not on a weekend, holiday, or a date the service, or sorry, date the child or service provider was absent. And then if telehealth is provided, the location where the student is, that the service is being rendered, and where the location of the practitioner is. And then if there's time that exceeds the amount of service on an IEP or FSP or other plan of care, it may not be billed to Medicaid, but there are some exceptions that we mentioned before. Your evaluations and assessments are not validated up against an individual plan of care. Those care coordination moments that might be for some unplanned services, or maybe for those new chronic conditions or suspected conditions, might not be covered. And then of course your IEP, IFSP time or time in a team meeting to coordinate care would also not be specified in an individual plan of care and would be allowed to be billed. But your time for direct therapy or group therapy or care coordination that's identified in the IPOP, you're tied to that time and you wouldn't be able to bill over that time. Your billing software has validation features in it, so it's important to note that all of your service time should be documented. That's important for indicating the exact amount of service that the students are being provided. And also can be useful in determining how much time you're going to place on an IEP or FSP or individual plan of care for future references. Some education agencies are doing some things manually and might not be using billing software that have these validation features. And in the event that that is true, if there's anything that you're documenting that you do not want billed to Medicaid, it's important to indicate that you do not want it to be billed to Medicaid. And that can be done by placing something like NB for not billable next to your service documentation. But just an important note, in general, it's important to document all services that you're providing. If there's something you don't want billed to Medicaid, you need to indicate that in some way and that's kind of an internal process that you would determine with your district. Okay, you can use abbreviations in your service documentation, but if they are used, you must have an interpretation of like for a permanent written record. So definitions for those abbreviations must be kept, like a code key of some kind. Documentation templates can also be used. Some student information systems that you're documenting in, or potentially your billing vendor that you're documenting in, might have like goals and objectives that are standardized with drop-down menu type things. But it's important to note that if you're including those things, that's okay, but you must document each unique service for that student and their specific response to the service. So templates are okay as long as it's not just a copy and paste type of thing. Any questions on best practices for documentation? We're at the time where you can ask all the questions. I think our slides after this are regarding resources, but any other questions? I'm flying. Paul, do you guys have any questions from the field or anything that you'd like to share or ask that may have come up before the meeting?
Nobody's raising their hand or has any questions.
Okay.
Okay. Well, as Lisa and Paula said, I will provide Paula with the slide deck and just some resources that she will pass along to you all. So thank you very much for being with us today.
Thank you.
Thank you, everybody. We'll stop record.